So I'd like to introduce Dr. Kravchuks. Dr. Kravchuks is an emergency medicine and critical care specialist and chief physician of the intensive care unit at the Emergency Medical Center at Paul's Strajan Clinical University Hospital in Riga, Latvia. He simultaneously holds the position of leading emergency physicians and head of specialized ambulance brigades at the State Emergency Services of Latvia. He's got a medical degree from Riga University, and he's a resident of emergency medicine, as well as certified in advanced life support, advanced trauma support, European trauma course, European pediatric advanced life support, and generic instructor course of the European resuscitation. He has over 14 years of experience in progressive emergency and critical care medicine, including senior roles in Latvia's largest territory level emergency departments and ICUs, pre-hospital emergency medicine as head of specialized ambulance teams, and international clinical observations at the University Hospital of Bern, Switzerland, Sheffield in the UK. So welcome very much and looking forward to your talk.
Thank you for the introduction. I'm glad to be here. Let me share the screen and we will start. Okay. Sorry. So you can see the screen clearly, and
yep.
I can. Okay, so my name is Evgenis Kravchuks. I'm an emergency physician. So, and today I will be present a clinical case about severe accidental hypothermia, which was successfully managed with the intravascular rewarming technique. So before I begin, I would like to say that I have no. Sorry. Oh, yes, have no conflicts. However, so this presentation reflects real clinical practice in our hospital and presented solely for educational purposes. So we were in close contact with the ZOL and Semetron representatives in Latvia. So for a small teaching how to use this machine, ThermoGuard XP. To understand the context, I would like to share some information about our hospital. Our hospital, one of the largest tertiary referral center with different departments, and of course we are one of the busiest and one of the biggest emergency department in the country, with annually about 59,000 attendances in a emergency department. So about 63 up to 70% of the patients who admitted to our hospital emergency department are discharged from the ED, and about 30% are hospitalized. So, and we facing increasing patients who are coming by not only by ambulance, but this chart is represents that more and more people came in our hospital by them. So our hospital is 840 beds. We're also clinical teaching hospital for residents. So and hoping. So this is on the left side. This is our on the first floor is our old emergency department, who is functioning for 20 years, and we hope we will get in one of these buildings, which in a few years. So. Hypothermia is a life-threatening condition, one of the emergency, pretty severe condition, which is associated with a high mortality, and particularly, especially in among elderly patients and those with a chronic disease and metabolic disturbances. And we will talk about the accidental hypothermia, which is defined as a drop in a core temperature below 35 degrees Celsius, caused by unintentional exposure to cold. So a lot of things going change during the accidental hypothermia. So, and not only the patient's general condition, but also different complications, and so actually very severe, critical and severe condition. So we all familiar with the classification about hypothermia and this Swiss classification for hypothermia when we use clinical judgment and patient assessment, and when we have this core temperature measurement, but in the hospital, when we have a core temperature, we can divide hypothermia in different stages: mild, moderate, or severe. And so, according to that, to this temperature measurement, we can adapt and start our treatment. And of course, the hypothermia, severe hypothermia, is associated with bad outcomes like death or the risk of cardiac arrest. That's why this patient should be this patient care should be really gentle, and of course, in the light of the light of the new guidelines, the 2025 of CPR guidelines in Europe, we see this hypothermia algorithms or protocol, which says what to do during the hypothermia. Of course, the ECMO is a rewarming gold standard for these patients, and our hospitals has ECMO team, and the ECMO team is available. But and it can be easily available in 6 hours according to these guidelines. But if it's not available, and sometimes in our hospitals even it's not available because of lack of specialists at that moment, or maybe machine is already busy. So we need to think about other methods of rewarming techniques which are available. Not only external techniques like simply removing the clothes, insulation, or make the room more comfortable and warmer. Of course, forced air, warming blankets, warm fluids, and internal techniques. It's if not available, depends on the local capability, and likely we have this machine which used in cardiac ICU for the therapeutic hypothermia in the patient after ROSC, and this year we try this for a hypothermic patient to rewarm them. So this is the first time, and we'd like to also share this case with. And we also make some small research in our own department, and yes, last year we have 24 hypothermic patients, and key points from this our local data set said the mean age is around 65 years, majority male, and 75% with a severe hypothermia. And the leading contributed factors was electrolyte imbalance, alcohol intoxication, and infection. Laboratory findings demonstrate different levels of acidosis. Most of them was acidotic, elevated lactate levels, and electrolyte abnormalities. The mortality rate is quite high, about 25%. It's six patients died. 4 of them was already in cardiac arrest when they arrived, so there was limited time to help, even with ECMO or other techniques to rewarm. So it was a very short time for them in our ED, but most of them was treated in our department, and some of them also discharged from emergency department. So. Now let's move to the case presentation. So as itself, and we received a 72-year-old male with chronic alcohol misuse, found unconscious on the street during cold weather. It was on the 25th of September this year. It was the first day in this season when it was really, really cold. And the estimated initial temperature was about 26 degrees. So he was presented with bradycardia, 44 beats per minute. He was with a low GCS and severe lactate acidosis with elevated lactate up to 13 millimole per liter. And we immediately identifies this patient as a good candidate for the intravascular rewarming methods, and so we started to implement this immediately. So we have one machine, the ThermoGuard XP system, and place the IC femoral catheter and achieving the rewarming rate at a maximum mode for 1.47 degrees per hour. And we achieved normothermia for the, to the first temperature target was 33 degrees, less in the 4 hours. Likely we have no any complication occurred like arrhythmias or hypertension. And after completed this rewarming process, the patient was transferred to the ward next day with full recovery and discharge on the after the week of treatment. So of course we used also different type of rewarming techniques like warm blankets during the all acute care in the our ICU. He received about 3,000 milliliters of crystallite during the first hour. Of course, there was some electrolyte disbalance like hypokalemia, which was corrected, and hypoglycemia also was corrected. And when the first target temperature was achieved, we do the CT scan with no sign of trauma or any infection, and we proceed with the treatment and achieved a good diuresis for the patient. So this is our small shock room with the 6 beds where the machine already in place and the rewarming is ongoing. So this machine is in the elevator, so we need to bring this machine from the ICU, which is one floor above us. So it's as for the first time, it's take about 1 hour to establish this machine, because we have to find the person who will connect the machine, who will bring the machine, and so it's a little bit longer. What I can say, we have another case also treated with intravascular rewarming, but it was much faster because we already know how to implement this. So now will be the small video, and I will just comment. So this is a cardiologist from the ICU who was already putting the IC catheter in the femoral vein. So we asked him to do this procedure for the first time in a hypothermic patient. The machine was already on standby. The nurse from the cardiac ICU was preparing the machine, and here is a patient with showing he was hemodynamically stable all the time during the procedure when the catheter was inserted. So the good femoral vein localization, there is using the ultrasound to landmark this possible the place for the puncture. So just to make clear that this procedure is not differs from the central venous catheter implementation. So so it's pretty the same. Just because this catheter is much longer and it has balloons on the end of the catheter, at least 3 of them. So more care should be done before we putting this catheter inside the vein. And also the guide wire is much longer, and when the simple central venous catheter. So all this procedure is done in our shock room. And the patient received a small doses of midazolam for sedation because he was agitated and not really cooperative. And I think with this procedure was nothing like there was no difficulty with inserting the catheter. The doctor was experienced in placing such kind of catheter, and I think when he put the guide wire localized and confirmed with the sonography. So and the machine was already in place, and here is the catheter, which is put in on the wire. and and something resistance occurred during the passing through the tissue, but since you put this IC catheter into the place, it's functioning like a central venous catheter, and you can put this catheter to the machine. So, and this graph shows what the temperature was achieved during the rewarming process. So this is a dot, the point when we started, the patient temperature was 25.5 degrees Celsius. And you can see this smooth, gradually increasing of the temperature during this first 4 hours until we reach the first target temperature, 33. This gray period of the time represents when the patient was disconnected from the machine, and we have to transfer him to the computer tomography. And then after the computer tomography, the patient started rewarming process again. So this 4 hours was at the max mode, which retrospectively we find that it was 1.47 degrees per hour, and then continue with the max mode until we reach the second target temperature, 33 degrees. So this shows the patient hemodynamics. So there was an increase in heartbeat during the warming process, but without arrhythmias. It just was sinus tachycardia, and there was no significant drop of the blood pressure. So we don't need to put the vasopressors on these patients. So different types of hypothermia treatment protocols exist in different institutions, and all of them are saying that if you don't have ECMO, you don't have intravascular rewarming devices, you have to proceed with standard basic rewarming methods. And I found another case report in 2008. The case report where the similar techniques was used, a similar device, and the patient was rewarmed successfully in a very short time without any complication. And also the colleagues from Germany in 2017 presented a case with accidental hypothermia in a patient who was 19 years old, and also recommends this type of way of rewarming patient using intravascular methods. It's heating for 1 degrees per hour during the first phase until we target the 33 degrees, and then we'll lower the rate to 0.5 degrees per hour until the target temperature of 36 degrees Celsius achieved. So can we say that it's general recommendation, or maybe it should be a new standard for the guidelines in the Europe? So we'll see. Our cases also represent similar data without any complication or arrhythmias. So to summarize this case, so we proceed with a fast and documented rewarming rate with intravascular technique, and this total time of 4 hours was spent, and we successfully rewarm patient to the safe core temperature when we can do some exams or give a medication, and without any adverse hemodynamical effects. No vasopressors, no arrhythmias, despite starting from less than 26 degrees, and no core after drop. So full neurological recovery. And the next day I was talking to this patient. He was, of course, he did not remember what happened with him. He just remembered he was, last what he was remembering was the place where he was sitting, and don't remember anything, but was fully without any neurological deficit. He received 1 week treatment in general ward because he has a urinary infection. He received antibiotics and correction of the hypokalemia, and was discharged. And while we're using these intravascular rewarming techniques, we can monitor the core temperature continuously, because the temperature detector is placed in the urinary bladder, so it's very reliable measurements. And this catheter, IC catheter, can be used as a normal central venous access to give fluids and any medication. And of course, this short ICU stay possible. We treated all our patients mostly in our resus room, and generally, if there is no like a bad outcome, like death of the patient, so they are treated and sometimes even discharged from our department. So no unnecessary burden of ICU, which in our hospital it's their limited ICU beds. So thank you for your attention. This is all from me. So and I'm ready to answer the question.
Excellent. Thank you very much, Dr. Kravchuk. One question. When you were talking about the other factors for the patient, such as electrolyte imbalance or alcohol, etc., does that factor, in your opinion, the efficacy of the rewarming, or is there anything where you watch out for certain types of patients due to that, or doesn't really impact your decisions?
You see, this case represents that the patient has no obvious trauma, no obvious like severe condition. So we decided to rewarm him with this. But these electrolytes abnormalities, of course, can affect some arrhythmias. So I think that early recognition of this electrolyte disbalance should be addressed, and as a lot of hypothermia protocols and guidelines says that we should aggressively treat the hypokalemia, hypomagnesia, or other disturbance. But in this case, there was no any difference to this. So the warming process was really smooth, and we just corrected slightly these abnormalities. And yeah.